hip replacement is the single most successful operation in all of medicine, single most successful intervention in all of medicine in terms of relieving pain and improving quality of life. So that is the biggest benefit of this operation, is the ability to return to normal daily activities without being constantly limited by pain in the joint. Also, the ability to sleep through the night without being woken from pain is another big thing that people notice. All these things help to improve activity level, which we would hope would cause people to be more active and have a healthier lifestyle.
The risk of infection is less than 1%. We do a lot of things to prevent infection. We have specially designed operating rooms. Patients are given antibiotics before and after surgery to again prevent infection. Now, infection, if it occurs, usually occurs early after surgery. So most infections we see in the first few weeks after surgery. Fortunately, most of them are superficial skin infections which can be treated with antibiotics. But very rarely we do get a deep infection around the prosthetic joint.
Once you have infected foreign material in your body, just giving you antibiotics is quite often not enough to get rid of that. And then you're having to look at having repeat surgery in order to get rid of the infection. Sometimes multiple surgeries, which may include having to actually remove the implants that we've put in.
Infections can also occur late after the implantation of the device, and this usually occurs in relation to things such as dental work, where patients are subjected to procedures where bugs can get into their circulation, and those bugs can filter out in their prosthetic joint and cause a late infection. So we do counsel patients after surgery that they do need to take antibiotic prophylaxis before they have dental work or other procedures such as a colonoscopy.
There's also the potential for getting blood clots forming in the veins of the leg. That's called deep venous thrombosis. And our concern isn't so much that the blood clot is in the leg. That will cause some pain in the leg will swell and be uncomfortable. Our real concern is that those clots can break loose and travel through the system and end up stuck in the lungs. And that's called a pulmonary embolus. And that, if it occurs, can even be fatal. Again, the rate of pulmonary embolus after surgery, and not necessarily fatal ones, but just ones that's significant enough for a patient to notice, is less than 1%. But it is something that we do take quite seriously.
It's very important that patients are aware of the risk of blood clots, and it's very important that they follow the recommendations that the surgeon provides to them in relation to blood clots. The most important thing is that they will be given blood thinners to take for a month after surgery, and that's because the risk of blood clotting persists for a month after surgery. So it's critically important that patients understand they need to continue with their blood thinners once they go home after surgery.
There's a risk of having any operation. This operation is done with freezing in the back so that you can't feel your legs, and then the anesthesiologist will, in most instances, give you medication to sedate you as well, so that you just have a nice snooze and you wake up and it's all done. However, the anesthetic itself changes the way your body systems are working, and then the stress of the operation, because even though you can't feel it, essentially you're having a trauma to your leg. It's a controlled trauma, but it is a trauma nonetheless. And trauma causes your body to release various chemicals and stimulants that affect your blood pressure, your heart rate, the way you're breathing. So all these things combine to put stress on the body. And that stress can lead to medical problems. People can have heart attacks, they can have strokes, and rarely even death can occur. The risk of these really significant complications like that is less than 1%, but it can happen.
That generally occurs in patients that have pre-existing medical conditions. So patients who have hypertension, diabetes, lung conditions, patients who are overweight, or patients who are very elderly are more prone to get those medical complications. And one of the things we try and do prior to surgery is to make sure that patients have those conditions optimized prior to surgery so they're not at increased risk after surgery of having those types of complications.
Another concern with hip replacements is that there is the possibility for that hip to come out of joint or dislocate. Okay? Basically what that means is that the ball comes out of the socket. And that risk is really highest in the first few months because we've cut the supporting tissues around the hip, and those need time to heal. So during that 3-month high-risk period, and when I say high risk, it's 1 or 2% of people who will get a dislocation. But during that first 3-month period, people are required to follow certain restrictions. Not allowed to flex their hip past 90 degrees, they're not allowed to bring their knee across the mid portion of their body, and they're not allowed to turn their foot, because those are the higher risk movements for a dislocation. After you've passed that 3-month mark, the risk of it coming at a joint significantly decreases, but it's never completely gone for the lifetime of the hip. Even years down the road, an awkward fall or something that could potentially cause a dislocation to occur. With hip replacement operations, it actually is possible to change the length of a patient's leg. So we do our best with your x-rays, helps us to plan the operation in advance to figure out where do we have to put all our components in order to ensure that we've got our leg lengths equal. However, sometimes that plan, when we try to implement it, is not adequate, and we find that the hip is not stable enough, is going to come out of joint, and we have to tension the muscles enough to hold it in, and sometimes that can result in the leg being longer. And that would be the most common thing. If there is going to be a difference, that the operated leg would be longer than the other side. We're pretty successful at keeping that within a centimeter, which is less than ½ an inch, and most people wouldn't even notice that, even if there is that difference. But sometimes for technical reasons it can end up being even longer than that, and it could necessitate the need to wear a shoe lift. That's not common, but again, it can occur. There's also the potential for bleeding and needing a blood transfusion. We find that about 1/4 to 1/3 of people who are coming for hip replacement will need a blood transfusion. It's very rare that that blood transfusion would ever be given in the operating room itself. It's usually in the first 2 to 3 days afterwards, because even though there's bleeding at the time of the operation, there's also some ongoing bleeding after the surgery is done and the skin is closed.
Since post-operative bleeding can cause some patients to show symptoms of anemia, you and your primary care doctor should be working together to optimize your hemoglobin before surgery. The Winnipeg Regional Health Authority Blood Conservation Service can help patients in achieving this optimization. Patients can learn more about anemia, blood and blood transfusion risks and benefits by visiting www.bloodconservation.mb.ca or by phoning 204-787-1277.